Hi, everyone. Good evening. We're going to give it just a moment to let everyone get in. This is going to be a fantastic webinar. I think this is my first time hosting a panel, so I'm very excited to have lots of people joining me tonight. Let's see. Well, I'm going to get started because there are a lot of people on here who have a lot of wisdom to share. So good evening and welcome to tonight's Wu University Fielding the Questions of Your Keratoconus Patients. I am joined by three wonderful doctors. We have Dr. Christine Sindt, Dr. Tiffany Andrzejewski, did I get it?
You
I did.
did.
And Dr. Mitch Ibach. I'm your host, Dr. Jennifer Stewart. One more quick housekeeping before we start. There's another poll that's launching in the chat to assess your experience with cross-linking. So answering a few of these questions before the lecture begins really helps WooU receive grant funding to help host wonderful events like this. So please take that poll before the webinar starts. So in the essence of time, I am not going to read everybody's bio, but welcome Dr. Christine Sindt. She's a graduate of Ohio State University College of Optometry. She's the chief clinical editor for Review of Optometry and serves as the associate editor for Review of Cornea and Contact Lens and Optometry Times editorial advisory board member, amongst a lot of other amazing things. Dr. Mitch Ibach is residency trained optometrist at Vance Thomas Vision. And he is, let's see, what else can I pick out? He's a fellow of the American Academy of Optometry, an intrepid Eye Society member, a board member for the International Keratoconus Academy, a member with the American Optometric Association, as well as many other amazing things. And Dr. Tiffany Andrzejewski completed her residency in cornea and contact lens at Indiana University. She resides currently in Chicago as an optometrist at Chicago Cornea Consultants, where she has worked for the past 12 years. So welcome to the three of you. With that, I'm going to turn it over to you. I will be in the background taking notes on some questions, and we will leave plenty of time at the end. But now I'm going to turn it over to you three.
All right. Thank you so much. Tonight's lecture, I think, is a really interesting way of looking at keratoconus because we're going to not just be looking at the facts or how do you just answer questions on a fact basis. We're really going to be thinking about it as if you were did my slides just disappear?
They did.
Yes.
Okay, that is interesting. Excuse me 1 second. I apologize. Hey, maybe one of the two of you could pull up the slides and I will stop sharing.
I'm working on it now.
Thank you very much. I don't know why everything just went black. But one of the interesting things about keratoconus is we have all these facts that's wrapped around it, but there are people wrapped around keratoconus, right? And so I always say if I had eyeballs sitting in my chair, it would be a whole lot easier than the people wrapped around the eyeball sitting in my chair. And they bring their hopes and their fears and their concerns. And so sometimes when they ask us a question, they're asking maybe a facts-based question, but I'm not really sure that the question they're asking isn't deeper rooted in them. And these questions really label them as difficult maybe to work with or have fears that are uncomfortable for us to sit with, right? Because we have to sit with them in their discomfort as well. And I think keratoconic patients really kind of get a bad rap for some of that. Okay, do we have that shared now?
I can see it on my end. Can you guys see it?
I
Yep,
can as
looks
well.
good.
Yes, thank you.
Okay, great.
Okay, wonderful. So why don't we start forwarding through some of these slides here. So today's question is fielding questions for the keratoconic patient. And as I mentioned, the keratoconic patients have this crazy personality that they get. And there have been studies that have looked at the keratoconic patient personality. So what has been your experience with this?
I would say it's always interesting. So I work in a high volume cornea practice with cornea specialists, and sometimes my front desk staff, they will, if they're feeling like a patient is a little aggressive or just asking a lot of questions or is demanding, they'll look at us and say, oh, that patient must have keratoconus. And so sometimes I find that my staff will stereotype these types of patients with this condition, where it really isn't true. Sometimes these patients are the most lovely patients in my practice. They are wonderful, but it's really just a lot of times they're wanting to understand their condition. They're wanting to be heard. They have a lot of concerns and anxieties wrapped around this condition. It's kind of like you said, Chris, it's not about, our lives would be easy if it was just about the eyeballs, but we have this patient and we have these feelings and emotions wrapped around these eyeballs and what this condition drives their thoughts.
Yeah, I agree, Tiffany. I think the root of a lot of the keratoconic patients and this profile here is really being misunderstood. I think we just can't see the world how they see the world. And I think these patients often have a difficult time conveying to us what they're seeing or what some of the frustrations are. And we haven't walked in those shoes or looked through those eyeballs. So that can be really tough. I think the second thing is these patients year after year after year have been told they have a chronic condition that doesn't really have a cure outside of a big corneal transplant, which is now being labeled, and probably rightfully so, as kind of the biggest hammer in the toolbox. And so these patients are scared, they're misunderstood, and then they also have a chronic condition that we really can't cure. We're just trying to support them to get them to a better spot. I remember coming out of residency for young docs who may be listening, and I thought, I got to learn all this stuff so that I can just have these cookbook ways that I'm going to take care of patients. And then after like the second or third year in practice, it's no longer about diagnosing the condition or what treatment plan we should put in front of them. It's about the psychology of that patient and trying to handle the tough patient or the tough scenario, not your average keratoconic or glaucoma patient that comes in. It's how do you connect with that patient, by the way, in a quick and timely fashion so that you can get on to the next patient. That becomes a difficult part of things. And so I think trying to understand these patients is kind of step one.
Mm-hmm. Absolutely. Let's go to the next slide. Yeah. And I think, Mitch, this is what you just spoke to, this concept of no one understands what I can see, because 2020 doesn't mean 20 happy, right? 2020 doesn't mean that they're functioning or that they feel like they can drive at night. And go ahead and click again. And so I think these patients are just absolutely confronted every single day with the limit of science. Even if we do understand what they're seeing, or we can connect with what they're seeing, there's only so much that can happen. We can't actually solve the problem of what they're running into in many cases. And that kind of puts people into a cycle of grief sometimes.
Yeah, I think this is a classic scenario of visual quantity versus visual quality.
Right.
We think so much about what we can get a patient to on the 2020 Snellen chart, and it doesn't always translate to what they need in their life. And so I started to try to connect with patients by saying, hey, I know you read well on the chart today, but that's black letters on a white screen in a dark room. Maybe it doesn't translate to what you're seeing on that stop sign. Or by the way, it's kind of a doubled image there for these patients. And so quantity versus quality, and then trying to understand, because I think for us, it's ingrained in our minds after our school and training that we got to get to that acuity level. But sometimes 2030 is better than 2020. And it doesn't make sense to us. But in my practice, we'll sometimes do surgery on a patient, whether it's for keratoconus or something else, and the patient's disappointed because they say, no, I see worse. And I'm like, no, you see better. This is objective. And they're like, no, I see worse, and I wish I didn't do this. And so I think that's difficult. Tiffany, I don't know how or what you do for these patients, but I think it's a quantity quality thing.
Oh, it 100% is. I mean, how many times do we hear that patient with keratoconus saying, yeah, I can see that, but it's not sharp. It's doubled. It's tripled. When the lights get dark, I can't see. When I'm on screens, everything is far more distorted. And so I'm constantly telling my patients, hey, it's not about, what you can read on the eye chart. That's a very antiquated way that we have to measure things for, comparison and consistency, but it's what your vision is more than that. And sometimes, telling patients that and saying, hey, I can't see through your eyes, but I do understand, can be helpful. And I find that also adding, other instrumentation to kind of walk them through some of this, which we'll talk about later, can be helpful too.
Yeah.
All right. So as we think about how to talk to patients, really our understanding of medicine in general and what I have seen happening through the College of Medicine and how we are now trained here at the University of Iowa is we've shifted from the what's wrong with you way of training people to the who are you, which is called trauma-informed care. And what this means is we are using people's backgrounds and who they are, where they come from, their past experiences to guide us in what treatments we may use moving forward. So the what's wrong with you is just basically looking at your diagnosis, giving you facts about your diagnosis, and then, pushing somebody out the door. Hey, this is what you have. This is what you need. This is what your surgery you can have. Goodbye. Versus the trauma-informed care way of doing it. And I have to say, it's really transformed my practice and how I think about things. Is if you have somebody that has past experiences that perhaps are less than, right? We have somebody who maybe has tried a contact lens in the past and has had a bad experience or ended up with an infection and they've had a bad experience with that. We have to address that past. We have to address their previous traumas in their lives before we can move forward with a treatment plan. So we have to say, I understand that you've had an infection in the past, and this is how we're going to mitigate those risks. Or I understand that you've tried a contact lens in the past and couldn't handle it. This is how we are going to treat you moving forward so that they can be part of the care process. And that's how I'd like to really think about these questions, fielding questions from these keratoconic patients as we move through this lecture, is shifting from the what's wrong with you diagnosis to the who are you way of handling the questions.
Yeah, I think this is an interesting picture, and all of these bubbles really resonate because all of these have happened, right? I had a patient today who missed her 1 month post-op visit, and she said, well, my husband actually passed away that day. And I'm like, well, gosh, it's a week later. Like, you could have skipped this appointment too. Or the patient that you're talking to about keratoconus, and they say, well, what about macular degeneration? No, you don't have that. Okay, well, let's go back to your keratoconus. They're like, well, no, my sister has macular degeneration. She lost vision from it. And all we want to do is keep going back to the fact in front of us, not really what our patient's concerned about. And then, Chris, you and I practice in kind of a similar demographic of patients where patients are traveling a long ways to see us, and 4 hours to one patient is less than 25 miles to the next. And so I have some patients who see me every 3 months and they drive 4 hours. And I have some patients who are like, I absolutely can't do that. There's no way I can get the 25 miles into the big city of Sioux Falls. And so it's different for every patient. And I think, so many of these focus on driving. I think in a lot of our older patients, but a lot of our keratoconic patients as well, driving is associated with kind of freedom. And if a patient loses that, then they always need someone to help them.
Absolutely. So, we find that there's seeking, and with all of our patients, really, there's these information seeking behaviors and the way patients present, and they require sort of some different approaches on that. I know, Mitch, you had some stories about some of the questionnaire patients.
Yeah, these patients, I wish I could have made this mandatory for my residents to be on tonight, because I think as much of the attendees will learn about keratoconus, is just maybe how to talk with patients and try to connect. And, I'm still learning in this every day, but the questioner patient for me tends to be the one where I'm already behind in clinic. And I feel like I've delivered the facts to them. I've delivered what we should do, and then they have questions about keratoconus, or they have questions about something else, and I feel like mentally my time is up. And so it's almost an egg timer in my mind of saying, gosh, I got to get out of this room, and they're still continuing to ask questions. And I feel like as a patient, because I go see a primary care doctor or another provider, I can sense that. And I think our patients can sense that too when we're trying to get rid of or get away from one more question in that scenario. The undecided one is another really difficult one. For me, it was probably 3 or 4 years into practice, and I was navigating how to really educate and deliver a plan to patients. And as I said, after your first couple of years of practice, then it just becomes doing that better. And my son at the time was 3 years old and needed to have tubes put in his ears. And my wife's a nurse, and we had done our research, and we had looked at the pros and cons and what type of tube should we do and what if they fall out. And the ENT came in, and he was a doc probably 3 to 4 years older than I am, but not aged in his practice by any means. And he walked in and he sat down and he said, "We're going to put tubes in your son's ears. We should do it in the next 2 weeks. This is what it's going to look like." And there wasn't any waffling. And so I think a lot of times our patients just want to know what we would do in their situation. If these were my eyes, these were my son's eyes, my brother's eyes, this is what I would do. And so I use that all the time with patients, because I don't think our patients need 6 options. If we tell them, you could do this, you could do that, you could do this, we could consider doing that. Now our patients are going, I don't know what number 1 was anymore. And so I try to have this is what I would do, unless it's gray. If it's gray, then I'll say, I think this is very reasonable. This is also, I'm 60-40. If I was in your spot, I would do this. But I try to lead the patient where I want to go. And then I'm going to steal one more, Tiffany, and then I'd love it if you kind of came back on some of these too. But the cross-checker one I just had with a keratoconic patient in probably the last 6 weeks. It was about a 15-year-old high school boy, and he came to us as a second opinion. And in general, I'm fairly humble. I don't have a big ego in practice, but in our area, we're the experts in keratoconus. And so came to see me, and I got done, and I delivered it what I thought was an all-star performance of, we're going to do corneal cross-linking, and we're going to get you fit in specialty contact lenses. And mom said, "That's great. We'd like to get one more opinion." And I kind of sat back and was like, "Why? Like, this is us." And she's like, "No, we want to get another opinion." And I think I went to the extent of saying, one of my partners in this practice was the medical monitor for the FDA clinical trial in cross-linking in the whole US. Like, what opinion do you need? And that patient went on to see 5 different providers before coming back to us. And it was, I think, and I don't have this instinct because I'm a dad and it's different, admittedly. It was a mom instinct of like, no, we're going to continue to make sure that everyone says the same thing. And then ultimately we ended up doing this boy's cross-linking. But that was a tough one for me because I felt like they didn't trust in me. And so being able to disconnect trust and fear, I think, is big in that scenario.
That's a really good point, Mitch, the fear aspect. And that's where a lot of these patients have that fear of the unknown and how does this, condition affect their lives, and they're looking for those answers, and they're looking to us for the answers. And so, sometimes you have that patient that's also, been and had those 5 different opinions, have seen multiple providers, and they have all this information. They've gone to Dr. Google, they've gone to, all of the reputable and sometimes non-reputable websites to find out information. And sometimes they're quizzing us. Sometimes they're, trying to check and seeing, can they trust us by asking us questions of what is our knowledge and do we have their best interests at heart? Sometimes we have that patient just that almost knows too much, and they're so focused on the nitty gritty where sometimes you have to, sit back and say, I appreciate all of your knowledge, and then kind of guiding that conversation. And sometimes it's also finding out, what do they know about their condition? I find that, I don't know with your practice, Mitch, but a lot of times patients who are coming into my practice, they've already seen my cornea specialist. they've had that diagnosis before they're getting to me, and they're looking at me for the next step in treatment options. And so sometimes I find it very interesting to sit back and say, I know you were just diagnosed with this condition. What have you read? What have you found out? What questions do you have? And sometimes that can really help facilitate that discussion. And kind of like you mentioned that, those questioning patients, sometimes also making sure that those patients realize as we go through this process, it really is a process that sometimes, we've got questions today, but you know what? I'm going to see you back for a contact lens dispense in a couple of weeks and then further checkup. Let's address some questions today, but we're going to have time to facilitate all of these questions, because sometimes patients have all of these questions and some are more in their forethought, and we want to answer those, but at the same time, we want to respect that in the time of our other patients too. So it's kind of a process of, working with all patients that have these chronic conditions.
I love that. One of my kind of goals in practice, I think last year that I wrote down, was I wanted to finish every exam with asking, do you have any more questions, or do you have any questions?
And sometimes the worst thing you could say.
Yeah. But if I could expand on that and say, time permitted, what's one thing about this that you wish you knew and you don't, rather than what are your questions? Because what you said there of like, what don't you know, or what do you know? Because it's so hard to know the baseline that the patient's at.
Or where they're getting their information from is sometimes completely wrong. And sometimes it's something that's instilling fear in them, especially if they're on social media and things and reading things. So it's good to know where they're coming from. And, yes, there are many patient support groups, but at the same time, I think we need to own as practitioners that we're the specialists of their eyes, because many of these patients don't just have one condition. Like you mentioned, you had, a patient that has family history of macular degeneration. So that's a concern. So it's making sure that we're addressing all of these concerns as a patient as a whole, not just a keratoconic patient. This is a patient with keratoconus.
One of the things I found is an interesting thread through all of these different types of information-seeking behaviors is, again, the practitioners are disenchanted with the keratoconic patient, right? They find them difficult. But everything I heard when you were talking about each of these information-seeking behaviors was something that you were annoyed with in yourself, from something that was internal to oneself, right? And actually not to do with the patient. I know I'm behind. I know that I need to get to the next patient. I think I'm the expert in the area, and I can't believe that the person is questioning me. And these are self things, right? And so there's something, patients that are seeking information often run into our own internal discomfort. And when we are internally discomfort, that's when we see people, these patients, as difficult, when really they're just trying to ask you their questions.
I think that's a great point.
Yeah. Let's go to the next slide. Now, we do know that chronically ill people, specifically people with keratoconus, do have anxiety, right? I think at this point, I think everybody has got some anxiety about something. But, where this study looked at the anxiety patterns in keratoconic patients, they say they have a greater feeling of loneliness or isolation, feelings of guilt, and fear of progression. Right. And how do you see those show up, or why do you think the keratoconic patient, Tiffany, why do you think the keratoconic patient has these anxiety feelings? I know we've talked about it, right? So,
well, I feel like there's a lot around it. Sometimes these patients feel alone. They might be the only person in their family or friends that have this condition. And unfortunately, they may have never heard about it. We know that many of our patients at large, they know about glaucoma. They've heard about it. They've heard about macular degeneration. They may know what cataracts are, but there's not a huge public service announcement about what keratoconus is.
There should be.
And they're correct. And it's webinars and stuff like this that are helping that. But, we used to think that keratoconus was something that was a very rare disease affecting 1 in 2,000. And sometimes letting these patients know that they're not alone, that there are resources, and that there are other patients suffering from it can be very beneficial. As well as sometimes they feel really isolated and guilty because they're wondering, what did I do? Why is this happening to me? And how did I contribute to this, and feeling guilty, as well as, what's going to happen to me now that I have this diagnosis. fear of what's next, or how is this going to impact my life, my goals, and things that I want to do and accomplish as a person.
Yeah. Mitch, I know you had brought up, that I don't see what the patient sees. Do you think that plays into this feeling of isolation that these people have? I look normal. I look normal, but I can't do things, or I'm going to say no because I know I'm going to be out after dark and I can't go socialize, or I can't go do the things I want to do because my vision is holding me back. But I look normal and people don't understand that.
Yeah, I think that's exactly right. Think of the last time you were in a situation where you wanted to be a part of a team or a group of people doing something, but you didn't feel comfortable because of XYZ. And so they have this feeling of anxiety or concern of what if it doesn't go the way that I'm hoping to. I think another big one is fear of progression. It's a real win for the audience. We made it to slide 17, and I haven't quoted anything or gave any stats yet, which is kind of my usual lecture ideology. But there's a great study out of AARP that looked at older individuals and their fears. And fear of blindness was number 3 behind cancer and stroke. And so our patients are scared of losing their vision. It's a big thing. There's another study by preventblindness.org that said of any of the other 5 senses, over 80% of patients said blindness or loss of vision was their biggest concern. And so we've now labeled, there's continued education on this, that keratoconus is a sight-threatening condition. There's the risk of going blind from keratoconus. And so I think a lot of our patients, especially who visit Dr. Google before they come to see us, that's one of the first questions that I answer from a mom or dad usually is, what's the chances that my son's going blind? And as soon as we can kind of stamp that one out, or say, we're going to do everything in our power to make sure that doesn't happen, we have XYZ to hopefully help that doesn't happen, I think everyone can kind of put their guard down a little bit and then start to take in the information that we're giving. But until that armor comes down, I feel like our patients, and especially parents with keratoconic patients, a lot of them being younger, aren't hearing the beginning of our spiel because they're still worried about the fear of progression and blindness.
And of course, it is very real that these patients can have very serious outcomes, right? So we can't blow it off and we can't make it too big, but we have to make them feel like they're handled. I had a patient today who, as a young girl, ended up with bilateral corneal transplants after a high drops episode, and now she has 2 tubes in her eyes and and two new corneas. And this is a big hammer, right? This was a very serious event that, I'd like to catch it much earlier, right? The earlier you can catch it, the more treatment options we have and the less risk for fear of progression, I think.
Yeah.
So Tiffany, you mentioned, something about telling the story and getting the information out of the patients, that it matters, that, we have to treat it. We have to hear their story before we can actually move forward with the treatment plan, right? And so how do you get patients, and Mitch, you mentioned this too, but how do you get patients to tell the story without having them start at birth?
Yes, because sometimes that is where they start. Well, sometimes it's starting with, more directed questions, less open-ended. Sometimes we all start open-ended, but sometimes you'll get a sense immediately of, okay, where is this patient starting? And sometimes you have to pull back the reins and make things a little bit more directed about, like you said, what do you know about your disease? And what other things have you tried? What are you struggling with from a vision aspect? You do have to be careful about sometimes what you say. What do you struggle with? Well, they can bring up a whole myriad of things that are going on with other body parts. And sometimes we do have to own that depending on what their major concern is and what's going on. But it's honing in on, where have you gone? What have you done? What have you tried? How can I help you? Because you're clearly here because something, isn't working. How can I help you see better? How can I help you sometimes be more comfortable? And what does that look like? And what are those various options? But sometimes knowing, what they've been through, like you said, the trauma, can help us better understand and guide our treatment plans and make sure that our patients are on par with what we think we want to do, right, to try to help them.
Yeah. I find that some of my patients, I think by the time they sit in my chair, they're almost like, oh my gosh, I'm here in front of you. I have to tell you everything all the time. I'm everywhere. And they don't even stay on the same topic. They switch between problems and they're kind of, it's a little intense. And something I've gotten better at over the years is saying, okay, specifically, I want to talk about this. And if they go off track, back to this. Like, we have to learn how to gently guide our patients to the answers with making sure they give us all the information, mind you. But I think they definitely need a little
Correction.
assistance, yes, in moving forward on the topic.
Yeah, I think of asking them to tell their story as being fairly synonymous with ask them their goals or expectations. My partner Vance will always say results equals satisfaction equals results minus expectations. And so you can have results that are off the charts, but if the expectations are even higher, you still don't have a satisfied patient. And so what is satisfaction to them, or what's the expectation or the goal that they're trying to get to? Because it's different for every patient. For some of our patients, it's not always better visual acuity. And sometimes I'll lose sight of that, specifically if a patient with keratoconus is wearing contacts or glasses and I fit them in a special contact lens. And now they have, different cleaners and it fogs up every now and then and all these other things. I'm like, well, wait a minute, we got 20/20 acuity here. I'm like, well, no, this is not as good as it was before. And so what are their expectations? What's the thing that's going to make them satisfied?
Right. And then you say it back to them, right?
Yeah.
Yeah.
I want to make sure this is what your expectation is, or this is what I've heard you said. I use that phrase a lot. This is what I've heard you say.
Mm-hmm.
And I will say it back to them in maybe 2 sentences. And if I have agreement, we can move forward. I will also write that in the chart, the synopsis of their story. And of course, you do have to give some facts, right? Like, we can't have all of this trauma-informed care. I mean, we do have to have the what's wrong with you conversation, right? We have to have the kind of the going over the basics, right? Mitch, you were talking about earlier about you have a spiel or something like that that you give people. Can you go over that a little bit?
Yeah, basically, whether it's in keratoconus or cataracts or glaucoma or whatever I'm going to diagnose and then educate that patient on, I kind of have a planned outline in my mind of what I'm going to say to that patient. And I do it just about the same way every single time. And I always start at the foundation. And so whether I'm the 6th provider that patient's seen on keratoconus or I'm the first, I'll kind of break it down with the terms keratocornea, conus, cone. And so rather than your cornea being shaped like a sphere or a basketball, it's progressively become thinner, steeper, and started to pooch or bulge forward like a cone or a nipple. And so I'll set that foundation for a patient. And then next, they kind of want to know when this happened. And so I'll say most commonly starts in our late teens to early 20s, but it's not like that for every patient. And then they're going to want to know, why did I get it? And there is a multifactorial reasoning for keratoconus. I think we can all agree on that. There's some genetic predisposition. There's the environmental factors. There's the mechanical stressors like eye rubbing. And so I'll talk to those about patients. I'm almost always asking about familial history, and it's maybe less about the patient in the chair, but more so that they feel armed to talk to family members about it, especially if they have children. And then eye rubbing. I talk a lot about eye rubbing. We have another slide coming on eye rubbing, but I think asking a patient if they rub and then catching them is one thing, but then also helping them to have resources and tools to lessen or stop their eye rubbing is a whole next step that we as keratoconus experts have to take.
Mm-hmm. And Tiffany, do you show the patients their topographies?
I actually do. Sometimes it's reading the patients, but I have many patients who've seen my cornea specialist and they just don't understand what the disease is. So I will show them their topography. I will make drawings If we're using anterior segment OCT for certain reasons, I will show that. I find that sometimes that's very powerful to understand sometimes the limitations of the science and technology we have and why things are happening and what we can do around that. I would say the piece of instrumentation that I think has made the biggest difference in my population of keratoconic patients is aberrometry. I have had many patients where we've done aberrometry and I've shown them and I'm like, this is not exactly how you see, this is an engineer's representation. And they'll look at that and they'll be like, oh my God, can I take a photo of this? Can I show my wife? Can I show my family members? This is what I see when I look at a stoplight. And they are floored. And all of a sudden there's a little bit better of a connection between us because now there's that physical representation on the screen. And that's been, I mean, I've had patients cry in the chair just showing them their aberrometry results because they're like, wait, you can now kind of see it. You understand. And that lessens a lot of patient anxiety. And sometimes that's a really strong connection point. And then all those, tests can then drive us to, what are those different ways that we can go that next step of helping them see better, but at the same time, making sure that they understand that unfortunately, these contact lenses are vision devices. They are not there to treat the underlying disease, which we're going to talk about cross-linking. That's, kind of a very clear crux of this lecture. But it's talking about, we have these different options to improve your vision, to help you be more comfortable, and things like that, and seeing what that looks like for the patient, depending on their past experiences and limitations and dexterity and all the things involved with, contact lenses. And sometimes contact lenses aren't the right choice for some of these patients as well.
Mm-hmm. So let's move on. So let's talk about reframing some of these questions from the what's wrong with you, like we have to give them the what's wrong with you answers. I'm not saying that you don't, because they do need these facts, right? But also thinking about it in the sort of the who are you direction here. So, we mentioned like, will I go blind? Can I be cured? Why did this happen to me? Right? But what are these patients really asking when they're asking these questions, right? They're asking very personal things like, did I cause this? Will my children get this? And these are very emotionally charged. So how do you go into these areas and start answering these questions? Maybe the questions that the patients don't actually ask you, right? So
I think for this, I'll talk about the genetic part to patients, but I don't spend a ton of time here. I'm going to probably try to get a lot of these questions when I'm saying, like, what questions do you have? How can I help you understand this better? I think our patients care a lot about the bottom two. How am I going to do my job and how am I going to drive? And so I will sometimes set up the goals that I have for a patient on an acuity front, depending on what they need to do for their job or to pass licensure for driving daytime only or daytime and night. How are we going to get to that? Because if I have a patient who I'm having a hard time getting some of these things from, I think that's a pretty synonymous goal of most patients is they want to continue working and they want to be able to drive to work. How are we going to accomplish that, or what's a game plan to get there?
yeah, I think, and maybe this is where I kind of lean into my experience, but when I ask them what your job is, I will then circle back around and say, are there specific things that you're having trouble doing at your job? Or are there specific concerns? Because they often won't bring it up unless I bring it up. But I'm at a hospital base, so I work with a lot of doctors and nurses, for example. So I understand that environment. Mitch, we are in a more rural part of the country. I have a lot of farmers, and so I have a lot of farmer specific questions that I bring up. Do you have to change your contact lens out when you're detasseling or you're not whatever? Hog farmers have a whole different set of questions than other types of farmers. And so, I over time, I've learned to hone my questions to specific jobs. If they're sitting at a desk, do you work long hours? Do you work nights? Yeah. Do you have to drive home or back to work? Do you work from home? That changed everything, right? working from home.
Mhm.
Do you want to keep working from home? Okay, how can I stop this? Right? You brought up eye rubbing, Mitch, but just telling somebody not to rub their eye, that's not terribly helpful.
Yeah. Yeah. So I used to just ask patients, do you rub, touch, press on your eyes? And if you do, then I'd say you have to stop. And then I took that one step further, and most of our patients, over 50% will have someone else with them in the room. And so I'll usually say, okay, now we're on a team here, and you're going to help when patient XYZ is not here with us. You're going to be the one that, and I'll make a joke of it, slaps their hands out of their way when they start to try to rub their eyes. And then I took it even one step further and said, do you know why you rub? And some of our patients will say, I have seasonal allergies and it just feels so good. Or right when I take my contacts out, it feels so good to rub. And so a lot of our patients don't even know they're doing it first. Number two, if they do, it's a habit. Habits are hard to break. And so I've tried to find team members or be able to align with someone to help in that patient's kind of not rubbing their eyes quest. And also then I'll try to educate patients and give them options on, if you're doing it, can we help so that there's less atopies or stimuli to do it, like treat their allergies or treat their blepharitis, or when you take out your contacts, put a cool compress on right afterwards, or something to help alleviate that. And so those have been helpful in some of my patients.
I think that's extremely helpful. Like you said, it's about giving them things that they can do versus they may not realize they rub. So by saying, have you thought about trying this or this or this? Because patients sometimes don't think of those things. What may seem obvious to you and I is not so often obvious to our patients. And sometimes they look at us to be that resource to give them those options to kind of help with those things.
Mm-hmm. Yeah, I will often suggest that they squirt their eyes out or make the saline cold, to stop that
Cold tears and
stimulus.
saline are a good one.
Yeah.
I think cross-linking questions or technical discussion is another big one. I think the majority of our keratoconus patients, hopefully I'm not the outlier, I believe are progressive or in the progressive years of this condition. And so after I'm kind of giving my outline of education to a patient, I'll say, I think of my job for you as two things. Number one, to halt disease progression or stop this from getting worse. And that's where, in my practice, cross-linking comes into play. But number two, we need to help you see better. We need to try to achieve your goals, because I haven't ever had a patient sit up from cross-linking and go, oh, wow, doc, thanks. I can see so great now, right? Patients don't come in to see us to stop their disease from getting worse. They come in to see us to see better. And so I think of my job as putting the pieces or the steps in the right order, but we need to finish the race, because if we just cross-link these patients or halt disease progression, I don't think they're satisfied. We didn't reach satisfaction. But if we just give them more contact lenses and help them see better and it continues to progress, I also think I maybe haven't done my job. And so I'm always trying to tell patients, this is the role I'd like to play for you. And maybe now, after working with you guys and kind of being a team member in this lecture, it's making sure I'm playing the role the patient wants me to, but also making sure that, I always say the patient's the bus driver, I'm the GPS. I'll try not to let them drive in the ditch, but I'm not going to tell them which turn to take at every turn. I'll just recommend the easiest way to go.
Yeah, because it definitely has to be a two-way street. And you're right. Every patient I've ever seen that's had cross-linking has been like, well, it didn't help my vision. And that's where it's drawing back to that. The goal of cross-linking is to preserve the vision you have. Yeah. And that's why I tell a lot of my patients, we recommend starting here, but then there are a lot of things that sometimes, get in the way of that, as far as what do they have going on? A lot of these patients are younger. The hardest part of the time of year I find in my practice is back to school, because sometimes we are getting these patients that have just been diagnosed, and guess what? They're going back to school. They're moving away for college. And now we're like, okay, what are we going to do for them? How do we get them the resources? How are we going to, get started in all of this? And sometimes that timeline and knowing what our patients have going on, what they are doing in their daily lives, that really drives this and all of our treatments for this disease.
Yeah. I think that final bullet point on the right is a really interesting one. Which eye should we do first? And I always think there's kind of three pillars in this decision. It's what do I think we should do as the doctor? What does the patient think that we should do? And then maybe what do some of the studies and the data say? And so I feel like as a doctor, we got to treat the worst eye first, right? This one's bad. We don't want it to get worse because it could go on to corneal transplantation. So we'll treat the bad eye worst. Our patients are very rarely ever going to say, hey, take my good eye and why don't you do that one first, right? They're always like, I want to dip my toe into this, so do my worst eye first. But a lot of the data on quality of life will say that maybe one of the number one drivers for patients is better, best corrected visual acuity and the better seeing eye. And so should we be saving the best eye first? Because that's what's ultimately going to drive quality of life. And so this is a conversation that I have with patients. I'm pretty upfront about it. I think in my practice, we probably do the worst eye first 70% of the time, though.
That's interesting. I think a lot of time the other discussion that I'm having with these patients sometimes in between their post-op period is, do we do crossing down both eyes and then do contact lenses? And sometimes I find that my cornea specialists forget to have that conversation of, what do you have going on? Life is still going on. How are we going to allow you to, function in between? Because sometimes these patients come to you and the disease is so advanced that they physically can't function right now and they need a solution. And then you have those patients that maybe can get through the post-op period of both eyes and then doing contact lenses and vision solutions together. So it's kind of looking at that from a very different standpoint and trying to help guide that decision with them and for them.
So when you help guide their decisions, like glasses, contacts, surgery, right? Those are very factual things, but talk a little bit about that, making some of those choices with your patients.
For the sake of time, I'll just take the last bullet point and say, I think so many of these patients come into us and they have found out they have keratoconus because they went in to try to have refractive surgery. And so then we'll talk about doing surgery and they'll say, no, I've been told I could never have surgery on my corneas because of keratoconus. Then we'll have to go into the education on, well, it's different for these patients, but I just want surgery and to get this over with. If we talk about some of the maybe vision correction options in keratoconus, whether it's things like CTAC or topography guided PRK, and I'm in just the kind of surgical realm right now, none of those procedures are really aimed at, hey, you're never going to have to wear glasses or contacts again, and just poof, this is going to be better. And so if you're working with a cornea surgeon that's doing these are really procedures to get into glasses and soft contact lenses, or maybe make scleral contact lenses easier to wear. But don't overpromise here, because this isn't like doing kind of refractive or vision correcting surgeries in a naive, healthy cornea.
Yeah, and it's really letting these patients know that even if they have a transplant, and I have many patients that come in asking for it, and it's just like, but you do understand that there's still a very high percentage chance that you're still going to need specialty lenses, especially because of isometropia and everything that we know with these patients, that, transplants are like snowflakes. Everyone is different. And, still making them understand that, sometimes the less risk is not doing surgery and trying to restore the vision first. And that can go a really long way. But part of it is also figuring out what vision device do we have in our toolbox that is going to meet these patients' needs. I have many patients that, they just look at me and they're like, I can't wear contacts. I'm not going to. They've had some sort of trauma, bad experience where they just literally don't like touching their eyes. And so sometimes it's, doing the best you can on a refraction, and nobody's ever taken the time to do that. And then they sit back and they say, this is actually pretty good. Sometimes you can really surprise yourself if you take the time and kind of guide these vision correction options to what the patient needs. Or, many times patients have failed with other, technologies and contact lenses, and figuring out why did they fail. For example, I had a young individual that, had tried sclerals elsewhere, and he's like, I couldn't get them in. Well, he also has a 10.8 millimeter cornea. he doesn't need a 17 millimeter scleral lens. He looked at me, I had no problem with soft lenses. I was like, okay, we can go smaller. And so sometimes it's looking at those things and why they failed.
Mhm. You know, you mentioned glasses and refractions. You know, I think that's someplace that we're going to see, you know, with aberrometry and using aberrometry. And, you know, I'm using a high resolution aberrometer in my practice. And I'm really finding that I can nail a lot of these refractions, which if I was trying to sort of hunt and peck for it, you know, with my old methods, you know, that was always more difficult for me. And so especially using visual Strel and looking at the different types of clusters of points in the eye, I think that we may be seeing that we can have functional glasses in some of these patients, you know, moving forward. Maybe not perfect, not like their contact lenses, but for some of our patients who we just don't want to be in contact lenses, we're going to have more options. So I think refraction is going to get to be exciting again, you know, as we move forward. But we're talking about contact lenses here, and again, for the sake of time, you know, Mitch, when do you tell people, you know, we talked about when can I go back to work? What kind of timeframes are you telling people?
Yeah, I think this is one is interesting because I'll usually tell colleagues that I'll try to wait 3 months before I do a new specialty lens fit after cross-linking. When is the last time your patient was ever like, yeah, I'm looking forward to 3 to 6 months, doc? They always want it sooner. And so I think this can be the lifeline for some of our patients to work and drive. And so I'm trying to be more and more flexible there.
Yeah, I typically start working with them at a month out and just make sure I'm working with a product that has an extended warranty on them.
Agreed.
All right, costs. God, don't you love talking about costs with your patients? Right? But we have to, right? This is a difficult conversation. And you know, you can't do this work for free. They don't really want you to do the work for free, right? They just want somebody else to pay for it. But you know, a lot of the things that we're talking about now, even some of the surgical procedures, Mitch, are not recognized standard of care, and so are out of pocket, perhaps procedures. And so, you know, you have to balance, right? Like what they're getting for what you're giving, and you're the best person to give it. And how do you bring up costs and talk about, don't talk about actual costs, mind you,
Yeah, no.
but how do you frame the cost conversation so that they can understand it?
Yeah, and so I'll always talk with patients that the goal of having insurance is to try to get these procedures covered by their insurance. And so medical procedures, things like cross-linking or corneal transplantation or and oftentimes CTAC in some of these patients is well covered by insurance when we do it properly and we go through the methods. I'm very insulated from cost because we have a huge team. I have 3 or 4 different people that help on the back end for this. And so I am it's easy for me to say, hey, we should just go down this road because I have a team that kind of supports me on that. I will say that costs of lenses can sometimes be a really difficult thing in my practice. And so I try to be upfront with patients on that because if they haven't ever worn specialty contact lenses before, we've just changed the game for them because they're used to getting a certain pack of lenses and it's $190 and it lasts them 6 months. And now we're saying this lens is $1,500 or more. And that can be a big shock to patients because it's just new. And so I try to talk about lens costs very early in the process.
Agreed. And sometimes it's spelling out those costs, giving them the hard data and numbers, giving them resources depending on, you know, insurance or care credit or other things out there to provide the financing. And I think a lot of times there's also a lot of hidden costs. You know, number of visits, time out of work. What does the remakes look like? What about cleaning supplies and the extraneous? Okay, a purchase with contact, but what does the care regimen look like? You know, is that going to be a limitation for these patients? And spelling that out can go a long way. I have had many patients where, you know, we've talked about different contact lens options or they've done some research and they're asking questions. And what may veer them going with one modality versus another is the time to that finish point. You know, I need the best thing that I can get as soon as I can get. They might have restrictions for travel, restrictions for work. And sometimes knowing those outside limitations that your patients have can help drive those conversations. And sometimes patients then are not afraid to sometimes pay a higher cost depending on what their expectations and what their needs sometimes are. Versus sometimes you do have the opposite of patients who, need something that's going to be more cost effective, and helping these patients understand that these lenses are an investment, but at the same time, if they're cared for properly and things like that, they do last longer than soft contact lenses, and having them understand that can sometimes help